Welcome, everybody, thank you for attending today's Network for Healthy Populations seminar, which is entitled Understanding the Social, Cultural, Environmental, and Systemic Factors Influencing Diabetes Prevention and Management Among South Asian Caregivers in the Peel region. So I think people are still coming on. But I think we'll get started just given the time and making sure that everybody, has a chance to speak and that we have time for questions at the end. So first, before we begin, I would like to begin by acknowledging the land on which we gather and which the region of Peel operates is part of the treaty lands and territory of the Mississaugas of the Credit. I would also like to acknowledge that I currently live and work in Toronto, which is covered by Treaty 13 with the Mississaugas of the Credit. We are all treaty people. Many of us have come here as settlers, immigrants, newcomers in this generation or generations past. We would also like to acknowledge those of us who came here forcibly, particularly as a result of the transatlantic slave trade, and pay tribute to the ancestors of African origin descent. We are grateful to have the opportunity to work on this land and by doing so, give our respect to its first inhabitants. So before I introduce you to today's speakers, I'd like to quickly review some housekeeping items. We appreciate our audience muting themselves during today's presentation. There will be an opportunity for questions at the end of today's session, and we will be inviting questions both through the chat box and by using the raise hand function. If you have questions during the event that you would like the speakers to address at the end of today's sessions, please enter them in the chat box. Lastly, please note that today's session is being recorded and we will make the recording available on the network's website that we will be launching in the coming weeks. So now I'd like to start with introductions. First of all, my name is Dr. Lorraine Lipscomb. For those of you who don't know me, I am the director of the Novo Nordisk Network for Healthy Populations at the University of Toronto. I'd like to introduce our three speakers for today. First speaker is Nusa Hafleen. She holds a Master of Public Health with a specialization in health promotion and health policy from the Dalla Lana School of Public Health at University of Toronto. She's a research associate at the Institute for Better Health, where she supports community-based research projects working with and amplifying the voices of communities in Peel. Nusa is passionate about advancing health quality with communities by using co-design approaches to develop and evaluate equitable and culturally safe programs and services. Our next speaker is Chelsea De Silva, and she is a research associate at the Institute for Better Health. She completed a master's in health sciences with a specialization in community health at the University of Ontario Institute of Technology. Chelsea is a mixed methods researcher and supports various community-based participatory research projects in Peel region. She focuses on engaging community organizations and people with lived experience to identify ways to improve the health and well-being of the community. Chelsea is passionate about using research to develop programs and services that cater to the diverse needs and experiences of our community. Very much aligned with what we want to do with the network. And finally, Dr. Ian Zenlea is a pediatric endocrinologist, clinician scientist at Trillium Partners and the Institute for Better Health, a part-time assistant clinical professor in the Temerty Faculty of Medicine at the University of Toronto, and he's also our lead for the Family and Community Health and Engagement for the University of Toronto's Network for Healthy Populations. At the Institute for Better Health, Dr. Zenlea leads the Family and Child Initiative, a community-based participatory research program aimed at co-designing, implementing, and evaluating interventions alongside community partners to improve the health and wellness of children and families in the communities where we live. So we're really excited to hear from these three wonderful speakers about the work that they've been doing in our community around South Asian health and diabetes prevention and management. So with that, I will turn it over to our speakers. Thank you.
Fantastic. Thank you, Lorraine. So Nusa will be advancing the presentation. And that was a wonderful introduction, wonderful land acknowledgement. I too live in Toronto, so I share the same acknowledgement as you. For disclosures, I have received some personal fees from Abbott Diabetes and Novo Nordisk Canada Incorporated, not related to this presentation. The other presenters have no conflicts of interest to disclose otherwise. Our agenda for today's discussion is to provide an overview of type 2 diabetes in Canada, both pediatric and adult type 2 diabetes, describe type 2 diabetes amongst South Asian communities in the Peel region, provide a brief description of some of the services for children and adolescents at Trillium Health Partners, and then introduce you to our study where we engaged caregivers who identify from South Asian communities in the region of Peel and understanding some of the sociocultural factors that impact their ability to engage in health promoting behaviors and support the health of their families. And all of the work that we're presenting today is really work that was led in partnership with our community partners. So just to start off, I'd like to acknowledge them, and they were Indus Community Services, Punjabi Community Health Services, as well as the Diabetes Management Center at Trillium Health Partners. None of what we're presenting today could have been done without their support and their leadership in this project. Next slide, Noza. So to provide an overview of type 2 diabetes in Canada, you can see that there are discrepancies and disparities based on race and ethnic origin. Based on the latest data, the prevalence rates of diabetes are about 14.5% amongst people from South Asian descent, which is the focus of today's talk. And you can see that compared to other racialized communities in Canada, and ethnic communities, these tend to be higher rates, prevalence rates across Canada in the adult population. For South Asian people and Black people, the rate is about 8 times and 6.5 times those among white adults. So again, comparing to the white population, you can see huge disparities amongst the rates of type 2 diabetes. For First Nations individuals, these rates are also as high and much higher, you can see, compared to the general population, which is about 5% versus 17% amongst First Nations. And the prevalence of diabetes amongst First Nation adults living off reserve and Métis adults is about 5, almost 6 times and 3 times as high as non-Indigenous adults. So again, type 2 diabetes tends to be a condition in Canada that is more common in racialized people. Next slide, Naza. For pediatric type 2 diabetes, it is a very rare condition, but that being said, the prevalence is increasing across the world globally and in Canada. It's a highly heritable condition, and most people, so as a pediatric endocrinologist, most of the people who I speak to about diabetes typically think of type 1 diabetes as a genetic or heritable condition. But when you actually look at the data in families across generations, nearly all of children and youth who are diagnosed with type 2 diabetes actually have a first or second degree relative who also has type 2 diabetes. So it's actually a much more heritable condition than type 1 diabetes. And again, children from racialized communities are at a much higher risk of type 2 diabetes compared to children who are not from racialized communities. And there are significant impacts of social determinants of health on this prevalence rate. And we see that youth with type 2 diabetes live below the poverty line or come from low resource homes. They're more likely to experience these structural and social determinants compared to those who do not have type 2 diabetes. According to the Canadian National Surveillance Study from the mid-2000s, there was a minimum incidence. So again, not a lot of children in Canada, thankfully, are diagnosed with type 2 diabetes. It's about 1.5 people per 100,000 per year. Next slide. And speaking to pediatric type 2 diabetes in Canada, you can see that most of the cases that were included in the most recent Canadian Pediatric Surveillance Program study from 2017 to 2019 were in Western Canada and Central Canada compared to Atlantic Canada. And these are actually, for this study, they didn't really differentiate between the types of diabetes. They just eliminated those with type 1 diabetes. So this was all cases, all comers with non-type 1 diabetes. And the majority of children who don't have type 1 diabetes actually have type 2 diabetes. And again, you can see that it's a pretty much an equal prevalence based on males versus females. Next slide. When we talk about type 2 diabetes in the Peel region, we're seeing significant impacts and high prevalence rates in Peel compared to the rest of Ontario. There was an amazing report, very comprehensive, very thorough, put out by our partners at the Social Planning Council of Peel in 2015. And in this report, there was a call to action to provide services and programs that were culturally appropriate to support South Asian community members. We were seeing an increase in prevalence over the past several years. And we can see that in Peel specifically from the late 90s to the early 2000s, the prevalence rate really has started to increase from about 6% to 9%. Next slide, Nuza. And here's just a graphical distribution of those data, which I just spoke to. And you can see compared to the rest of Ontario, the prevalence rates are much higher within the region of Peel. And they've been increasing in all of Ontario and Peel specifically since the late 1990s into the 2000s. And you can almost see that the prevalence for, or the rates for Peel versus Ontario, it's almost splaying at the end. And you can see that it's increasing a little bit more steeply visually from this graph in Peel compared to the rest of Ontario, speaking to the challenges faced by our communities in Peel when it comes to chronic disease self-management, the ability to engage in health promoting behaviors. And we hear from our community partners about challenges related to the social determinants of health. And again, the need for action within our community to support people where they live. Next slide. So before I speak to our specific study and turn this over to Chelsea and Nuza, I just wanted to make you all aware that we do provide services at Trillium Health Partners where we work and where our Institute for Better Health is situated. We have a pediatric diabetes education program, so we see many young people with type 2 diabetes within that program, as well as other types of diabetes. We have a KidFit Health and Wellness Clinic there, which is a pediatric weight management program that's been co-designed with families to support people living in larger bodies to engage in health promoting behaviors. And we have a very large diabetes management center to support our adult populations with type 2 diabetes. So this specific project that we're going to be speaking to for the majority of the presentation, led by Nuza and Chelsea along our community partners, really emerged through direct conversations with our community partners at Indus Community Services and Punjabi Community Health Services. Our Family and Child Health Initiative, which is our research team at the Institute for Better Health, had a series of conversations with over 150 community members who work in community organizations in the Peel region, who include some of the leaders in our South Asian community. Back in 2018, we had a series of conversations really to understand what some of the health priorities were facing children and families in the Peel region. And based on these conversations, we had submitted an application to the Canadian Institutes of Health Research. We were successful in partnership with all of the individuals you see here listed. And you can see that our community partners at the Diabetes Management Center, Indus Community Services, and Punjabi Community Health Services really led this project alongside us and helped us to develop the research questions, the research methodology, refine all of the study elements, including recruitment materials, interview guides. So really a collaborative community-based participatory approach here. And we were really so thankful to them for their support in this project. And again, none of this would have been possible without any of our community partners really leading this work and bringing that lived experience perspective. You know, as an individual who identifies as being a white settler, when we're thinking about asking research questions and conducting research in the communities and where we live and we share with racialized community members, it's really critically important that we engage lived experience, we honor those voices, we bring those voices to the table when we're developing research, because research should be action oriented. And that's what we hear from our community partners through all of our conversations and network tables. So I'll turn the presentation over now to my colleagues, Nuza and Chelsea, to walk you through the study and some of our findings and how they relate to the ongoing work we're having in the Peel region and with the Novo Nordisk Network for Healthy Populations as well.
Thanks, Ian. Just as a quick overview of the study, there's basically two phases to the project. The first phase was really interviews with service providers. We were really looking to understand their experiences supporting caregivers with type 2 diabetes who are South Asian and live in the Peel region, to really understand what they see across the populations that they serve. Through those interviews, we also use that opportunity to have service providers who work closely with South Asian families review the interview guide for phase 2. And phase 2 was really interviews and a social network analysis with caregivers who had type 2 diabetes and pre-diabetes, really looking to explore the social and cultural factors influencing type 2 diabetes prevention and management. Our hope was always that through this project and understanding the social and cultural factors, that we'd hopefully be able to understand different ways and different programs that might be able to better support families in Peel region. I'm going to take us through a bit of an overview of phase 1, which was the service provider interviews, and then Nessa will take us through phase 2 with caregivers. So with service providers, as Ian mentioned, this was a community-based project. So it was really key for us in step 1 to really have multiple touch points with our community partners to really understand what are the best ways to recruit service providers. What are some of the best questions that we should be asking service providers, knowing that they had really great experience working with different service providers already. We did a series of interviews with service providers, and the service providers will show you a little bit about the demographics, but really they were recruited through the Diabetes Management Center at Trillium Health Partners, through Indus Community Services, and also through Punjabi Community Health Services. We also developed together with our community partners an interview guide, and through these interviews, we were able to also refine the caregiver interview guide as well. And then we have qualitative analysis looking at the service provider interviews before thinking about some of the different ways that we've disseminated the findings. As we mentioned, we had interviewed 12 service providers. The age ranged from about 22 to 72. When we were thinking about service providers, it was really important for us to make sure that we covered a spectrum, not just healthcare providers, but also community health service providers and community social service providers as well, to really make sure we were able to understand the larger context that many South Asian caregivers are actually facing while trying to manage type 2 diabetes. One of the things that's important to draw attention to is that 10 of the service providers who were interviewed here were also South Asian. This provides kind of context for two pieces. One is that most of the people that actually chose to participate, we had asked that they primarily serve South Asian participants or South Asian community members. So many self-identified also as South Asian. And also that means as we were doing the interviews, they were able to draw both on their professional experience serving South Asian adults with type 2 diabetes, but also some of their personal reflections, knowing that some of them may have had pre-diabetes or diabetes themselves, or family members that also had diabetes as well. And then in terms of languages that they were able to speak, all of them could speak English, but about 10 of those service providers could also speak a different South Asian language as well. What we're going to do is take you through kind of some of the key findings from the service provider interviews. Next slide, Nessa. Awesome, thank you. So through these qualitative interviews, the first theme that we really saw as we were going through this project, Nessa, do you mind just flipping back slides? The first one was really speaking to how South Asian caregivers are really managing multiple challenges throughout their settlement process. And these often take priority over type 2 diabetes management. We can see in this quote here that we have a service provider basically saying housing's a bigger issue, immigration's a bigger issue, poverty is a bigger issue, domestic violence, addictions, mental health. These are all really bigger issues than diabetes in the community. And that the biggest issue for their community is the fact that Canada has been unable to address racism within the job market. If you come from back home to Canada with your education, they look at that degree as if you have literally no experience whatsoever. So really tying in that piece around discrimination in the workforce and how that impacts bigger concepts like housing, immigration, and poverty. And that those ideas and those structural components are really a bigger issue to many of the families than managing their diabetes. When we spoke to participants, we also asked them kind of a wish list, or if you had to think about ways to address some of these concerns, what would you recommend? And service providers really recommended that at a federal level, there needs to be more funding and policy interventions in order to prevent systemic discrimination related to employment. So again, looking at some of the structural barriers that South Asian families face while trying to find employment and trying to settle within Canada. The second theme that came out through our interviews were that poor working conditions and socioeconomic status often reduce access to healthcare and medication for South Asian caregivers. We have a quote here from a service provider saying, so when it comes to an appointment with a healthcare worker, that involves taking time off work, a lot of time. It involves transportation to our site, parking associated fees, or multiple bus routes. If you're using public transportation, it often involves necessarily a bit of wait time. So it's a tall ask for someone who doesn't have coverage or an employer that provides coverage or access to those services without jeopardizing their income. So again, this is really tied into that first theme. If you're not able to gain adequate employment, people are often in precarious employment without coverage for medical expenses, but then also without the flexibility to attend appointments, which are required for their type 2 diabetes management. When we spoke with participants, some of their recommendations were that service providers should highlight financial subsidies to support clients to ensure that those that have financial needs are aware of some of the resources that are available to them. Service providers really saw this as an important role that they can play, especially community service providers, in ensuring that families have the financial support that they need and are eligible for. And then the second recommendation was that service providers should provide accessible healthcare services, which are respectful of time commitment and resources needed to attend appointments. So this was a very sort of pragmatic logistics recommendation around being really mindful of people's time and the resources that are needed to attend appointments. And then the third theme that really came out through these service provider interviews was really around social, economic, and cultural barriers that really impact how we can implement diet and exercise recommendations. So if my clients want to go to a diabetic diet, you try to do it. Do you think that it's going to be more expensive or less expensive than the general food? If my client has 2-3 children and the family to support, do you think they're going to go for vegetables? Vegetables is most costly. If you live on a very limited budget, there's no options for individuals who are experiencing diabetes. So this really speaks to the financial burden of switching to a diabetic diet. But one of the things that service providers really highlighted was that oftentimes it's really difficult when you're immigrating to Canada to really understand what produce is available to you here that might not be as familiar. So many of their familiar vegetables or fruit are not easily accessible within like Canadian grocery stores. Participant recommendations were that service providers should aim to understand how the social determinants of health are impacting clients and aim to address those concerns. So if a community member is saying that they have financial strain, recommending resource and financially burdening recommendations might not be something that's feasible for them. And then the second recommendation was that government should move forward with policies to make healthier options more affordable. So really thinking about how we can increase accessibility. And that's the next slide. I think I'm going to pass it over to you to tell us a little bit about the caregiver interviews.
Thanks, Chelsea. And before I get right into phase 2 and the overview of phase 2 and caregivers. The first step of phase 2 was a partners touch point. So as we wrapped up phase 1 and finished interviewing service providers, we had data from the service provider that Chelsea just walked us through, but we also had data to really refine the interview guide. So part of our phase 1 interviews included, and the last section included walking service providers through the interview guide to ensure that the interview guide was going to be appropriate for caregivers caregivers. And we then took all of this back to our partners and our larger team and had a discussion about these are the kind of findings that are coming up. What should we do at this point? And in that meeting, we had decided that it was very important. The findings were very important from a service provider perspective, but the team really wanted to understand whether some of these recommendations were going to be mirrored and reflected in caregivers. And I'll also draw attention to the fact that what we mean by caregivers is that we're speaking to parents, grandparents, aunts and uncles that are living in a home with a child. So part of phase 2 recruitment for caregivers was to ensure that folks, these were adults living in the Peel region, identified as having prediabetes, gestational diabetes, or type 2 diabetes. Initially, we had just started off with type 2 diabetes, but again, going back to our partners, understood that it was important to include gestational diabetes and prediabetes perspectives of South Asian members as well. And they had to be living in a home with a child between 0 and 24 years old. We started then recruiting again with the support, tremendous support of our community partners, the Diabetes Management Center at Trillium Health Partners, Indus Community Services, and Punjabi Community Health Services, who are also then able to refer us to many, many other community agencies and organizations that were able to amplify our recruitment posters and recruitment efforts through social media. In step 2, we recruited and conducted interviews with about 21 South Asian participants, and I'll walk you through the demographics very soon. And then in step 3, we did the qualitative analysis. Part of our interviews for phase 2 included a social network analysis to really understand where people were accessing supports and who their supports were. Step 4 was dissemination, and step 5 was implementation. The implementation piece, we're going to be speaking to that towards the end of the presentation, which was co-design sessions with community members and community organizations to understand what they would like to see happen as with these results of the study. So the demographics for phase 2 caregivers, we had quite a variance in terms of age. We had the age variance was between 26 and 87 years old. We had, again, differences in their caregiver role. So we had about 7 mothers, 5 fathers, 4 grandmothers, and 5 grandfathers participate in the study. Their education level also varied between less than high school to a graduate degree. Because, again, drawing attention to the fact that South Asians as a term is a very broad term, and that incorporates a heterogeneous group of individuals that identify from very different countries and also have very unique cultural, lifestyle, and languages within each of these subpopulations. So oftentimes in the diabetes world, we categorize South Asians as one big group. But in the study, it was also important for us to have representation from at least the main South Asian countries. So we had participants who identified as Indian, Pakistani, Bangladeshi, and Sri Lankan. Their income levels varied between less than 49,999 to 100,000 and above. Their citizenship status also varied. We had 10 Canadian citizens and then 11 permanent residents. And most of our participants, 20 out of the 21, identified as being first generation, meaning they were born outside of Canada. And one participant identified as being born in Canada. So I'll walk you through now some of the findings for caregivers. So in our first theme, we really saw that there are multifaceted challenges with employment, income, and accessing basic needs, which impacts diabetes self-management. So again, very similar to what we found in phase 1. A participant highlighted this by saying, when over here, they're being treated as a second-rated or with racism or without any reference. We can't get any job, even on the road or even at a restaurant or even any kind of minimum paid job. Then obviously at that time, he's in stress. He's in stress. And what outcomes? If he has got a problem like any kind of disease, just like diabetes, it's going to worsen. It's not going to get minimized. So again, this participant is speaking to the challenges of accessing employment and income, and how then that is compounded with having to manage those accessing basic needs with diabetes self-management, and how those stressors are all kind of coming together to really amplify disease progression and management difficulties. So participant recommendations, similar to phase 1, we asked all participants what if they had a magic wand recommendation or a wish list item. Participants recommended that it was important to address discrimination and inequities in labor policies and barriers to basic needs. And this was speaking to the social determinants of health. Participants also identified that there was a need and an urgent need for type 2 diabetes management resources. So for example, glucometers and sticks were something that a lot of folks identified that they could not afford. Along with dental, eye, and foot care, so services that are not necessarily covered by OHIP. It was really important for advocacy for funding for those resources. Theme 2 was really looking at the caregiver role. So again, how family caregiving, roles of parents and grandparents, and how those activities are prioritized and impacts diabetes self-management. I also want to make a note here that caregiving activities vary depending on the caregiver role. So here, this participant identifies as being a mother, and she talks about, so a lot of times the kids need something. So I'm doing that, dropping and cooking, doing it for them. And then I'm like, oh, do I want to cook something separate for myself? Probably not, right? So the participant here is really speaking to making meals and balancing her needs for diabetes management with the larger family context, while she's also navigating multiple demands with caregiving. What we found that there was a difference depending on the role of the caregiver. So mothers often were navigating multiple different demands, and this is consistent with other literature, whereas fathers, many of the fathers in the study spoke to the financial stressors, especially when they were transitioning during the settlement process, and how that impacted their ability to manage their diabetes. Many fathers spoke about work hours, precarious shift work, and not being able to sleep well, not being able to manage their stress, and not being able to eat healthy meals because of the nature of their work. One participant was a truck driver and really emphasized how, depending on the nature of their work, it was difficult as a truck driver to be ensuring that they're having healthy meals. Grandparents had a different perspective. So grandmothers played a very supportive role with caregiving, looking after children, helping with meal prep, but there was also a sense of isolation and having to navigate a different system here and having to build supports here, and how that then impacts their diabetes. Grandfathers really talked about how their diabetes management was tied to the lack of their own financial autonomy now. As a result of transitioning to Canada, they weren't able, their foreign credentials were not recognized, and they were unable to secure work for their own. So they're often living in intergenerational homes dependent on their children, and oftentimes that income is limited, and so they're constantly considering the implications of asking for more within the limited financial resources that families are operating on. Participant recommendations in this theme really came out as type 2 diabetes prevention needs to be addressed at the family level to ensure that recommendations are feasible. Our last theme was really speaking to how there's challenges navigating the Canadian health and social service system. As you saw in the demographic information, many of our participants identified as being first generation. Many also identified as being recent migrants. 4 of our participants out of the 21 had requested for interviews in a South Asian language. So we did conduct interviews in Urdu and Tamil, and were able to translate it. So we also were able to understand how language plays a factor in accessing health and social service systems. Participants spoke about the difficulty of understanding and being aware of the different services that are available in Peel region, but also more broadly. They identified different components of health and social service systems that are difficult to manage, especially when there is a language barrier. This particular participant is able to comprehend English, and so he was speaking to English is perfect. Sometimes translation is very poor. They list perfect, explain very well, but translation sometimes poor. So in the larger context is this participant is really emphasizing that even when there is an effort within health and social services to translate resources, whether that be pamphlets or booklets, into South Asian languages, oftentimes the translation is poor and does not carry the same accuracy as the English versions, and the need to make sure that we're not just checking off a box for translation, but we're actually doing it with intention. Participant recommendations around this was that organizations should provide culturally and linguistically tailored diabetes education and diabetes management community supports. So what we did was, after phase 2, we brought kind of the recommendations together. So we were able to identify what was working well and what was not working so well, what the barriers were, but we really focused on some of the recommendations, and we were able to compare and contrast the service provider and caregiver recommendations, and a lot of them aligned. So for example, service providers recommended funding for health and social services, caregivers wanted funding for type 2 diabetes management resources, so glucometer sticks, dental, eye, and foot care. Service providers addressing discrimination and inequities in labor policies, service providers mirrored, caregivers mirrored that same concept, except they also emphasized the need to address basic needs related to the social determinants of health. Service providers recommended culturally tailored programming. Caregivers recommended culturally and linguistically tailored programming. Service providers recommended diabetes education and social determinants of health supports. Caregivers were a bit more specific that diabetes education should include visual media and type 2 diabetes management community support groups. And then finally, service providers recommended that there should be a resource list of type 2 diabetes and social determinants of health supports. And caregivers recommended that it was important to incorporate type 2 diabetes prevention at the family level. So having said that, we took these recommendations and back to our community partners, back to our larger project team, and really had a discussion. And before I get into that, I'm just going to highlight that one of the things that we're working on is we're really in that knowledge translation leg of the study, and I'm going to be speaking to that a little bit, but I want to highlight that any of our knowledge translation steps ties directly back to conversations with community partners and the recommendations that participants had highlighted for us. So with our knowledge translation and next steps, we have some manuscripts lined up. We've already published a paper in the Canadian Journal of Diabetes that Chelsea and I supported, and that includes the phase 1 findings, which is the service provider perspective on type 2 diabetes management among South Asian caregivers. Upcoming is the phase 2 findings, so the deprioritization of type 2 diabetes management. And then we're doing a separate paper on the social network analysis, which is really looking at the piece in the interviews where we're able to see and map out where people are accessing supports, including humans, organizations, and resources, and then being able to make sure that we're able to disseminate this information or incorporate them in our thinking for next steps. We also had 2 really outstanding occupational therapy students, Oniba and Mubina, join us during the project, and they did a secondary analysis from an occupational therapy lens on the data that we had from both service providers and caregivers, and they are currently drafting the role of occupational therapists in type 2 diabetes management among South Asian communities. So these are the manuscripts that we do have planned. We're also, what's important for and what we've heard from our community partners is that it's really important to ensure that there's a community advocacy report. So a report that really summarizes in kind of lay language, the pieces that in our study that are important as advocacy points. So as you saw, labor policy, labor market discrimination comes up as a really big piece. So does racism, so does advocacy for funding. So there's a lot of different points of data that could be summarized in an advocacy report that then our community partners are able to use within their own operations and logistics to really have solid data and evidence to back up what they're asking for. And then part of this, as you saw earlier in the study overview and in phase 1 and phase 2, is that we would do co-design sessions and collaborative grant writing. So we have actually done the co-design sessions and collaborative grant writing. Our August and September have been quite busy. Some of you on the call probably know and have heard from me. We conducted co-design workshops, and what these workshops are was we invited service providers, nonprofit organization leaders, community members, clinicians, researchers, alongside everybody else that was part of the initial project team to participate in two co-design workshops. The first co-design workshop was idea generation. So we just wanted to bring everyone together, present the overall findings of phase 1 and phase 2 as we have here. And we asked them a series of questions and really had them think through how they can potentially propose either a service, a program, which doesn't have to be net new, or adapt an existing service or program to address what's not working so well and what's working so well, and then also align with some of the recommendations that participants had made in the study. Here is kind of a very small screenshot of our mirror board. This is much larger in actuality. There's multiple sticky notes, but I wasn't able to kind of fit all of it in one slide. But we had a phenomenal session and had a lot of ideas come together. And within the first workshop, we really identified some main key action items. One was a series of different ideas, and which included like an intergenerational community-based diabetes education program, a community diabetes mobile clinic, an intergenerational community diabetes kitchen program, and then a series of ideas for project launch or knowledge translation and exchange events. What we then did was we also had other considerations, which are kind of documented at the top here. And then we had the entire team, so the co-design participants, vote on which idea they wanted to see move forward. So by workshop 2, all the participants in the co-design workshop had voted, and then we really went through idea refinement. So where we landed was the intergenerational community-based diabetes education program, and we walked them through a series of questions to really think through what other ideas needed to be incorporated within that specific idea. And we landed with the South Asian Family Diabetes Awareness Program. I will turn it to Ian to walk us through this and then close off.
Okay, amazing. Thank you, Noza. And we want to leave some time for questions, so we're not going to go into too much detail, but after the co-design workshops, we really started to think through how we could co-design an intervention and propose an intervention to really meet the needs of families in our community that address the social determinants of health. So the background of this proposal is that many of our community partners had actually been funded to have community health ambassadors as part of the high priority community strategy. And these community health ambassadors had been supporting families by providing wraparound services, addressing vaccine hesitancy, referring to vaccine centers, and were already employed at Punjabi Community Health Services, Indus Community Services, and our partner Roots Community Services Incorporated as well. And so we were thinking about how can we leverage this existing program that's already in place rather than inventing something completely net new, as the program is naturally evolving and our partners are advocating for continued funding from our Ministry of Health to change the Community Health Ambassador program from COVID-specific support to more chronic disease self-management support or disease prevention. So what we proposed here was based on the foundation of the Community Health Ambassador program. So taking those existing community health ambassadors and training them in system navigation, referring families to supports that already exist within the community to address social determinants of health, such as, financial strains, food insecurity, precarious employment, any services that can support people around their, skill building, trade, employment placement, housing, anything that we think based on what we know about type 2 diabetes prevalence and what we heard from our study. And then layer on top of that some education that's culturally safe and very specific to South Asian community, and to be family-based. So engaging caregivers again, but also bringing in adolescents. And one of our partners on this specific grant application, Ananya Banerjee, worked alongside Nuza on a program for adolescents, and a South Asian adolescent awareness program and diabetes awareness program, SADA. And so thinking through the work our partners had done with Nuza, and then also what our community had requested, really wanting to take all of that to action and build upon an existing program. So what we proposed here was a 3-year research study. We just submitted the grant last week, so we're all crossing our fingers, arms, and toes that we'll be successful with this application. If not, we will likely resubmit, because we believe that this is very important for our community. But consistent with all of our community-based participatory research approaches, the initial months are really to form a new community advisory board. So a group of people who are representatives from our community partners, as well as people with lived experience of having type 2 diabetes, and those would be youth and caregivers, to really guide the project throughout the duration of the project, having this core group that guides the project, that really thinks through some of our principles of collaboration with our partners, our ethical challenges related to conducting community-based participatory research, taking an equity, diversity, and inclusion lens, and really thinking about issues related to social justice. Is really critically important to how we conduct our research. So this group would guide, and then in the next few months, for the first year, it's really around hiring and training the community health ambassadors who may already be employed within these agencies and organizations, working in partnership with our Diabetes Management Center at Trillium Health Partners, hiring and training some new diabetes professionals who would be nurse educators and dietitian and kinesiologist to build a curriculum. So a 12-week educational program, and then enrolling some families from each of our 3 community partner sites to participate, and then really thinking through how we can evaluate the project, and again, bring it with continued advocacy, continued generation of evidence to really have the community health ambassador with a focus on type 2 diabetes prevention be something that many community partners in Peel could consider adopting and implementing, and then, something that we could potentially look at spreading across Ontario and even outside of Ontario. So this was our way of bringing people together, coming up with something that was actually, we thought was feasible, implementable, would reach a small group of people initially, be family-based, and be focused more on prevention and support. Many of our community partners are already thinking through how to develop type 2 diabetes specific programming. And that is also something that we're having conversations with our partners about, is, the treatment aspect. So how are we better supporting people who've already been diagnosed? As a pediatrician and pediatric provider, I do provide services to children and youth who have type 2 diabetes already, but we really wanted to take this intergenerational prevention lens, taking into account the statistic I cited at the beginning, which is that 90% of children and youth who are diagnosed with type 2 diabetes have a first or second degree relative who has type 2 diabetes. So how can we intervene early? And which groups of people? Here we focused on adolescents who are just starting to engage in independent health promoting behaviors and building the skills and the knowledge with support from their caregivers for that family-based approach. So this is what we proposed, and hopefully we'll be successful. And if not, we will resubmit and continue to work alongside our community partners. And, even though this funding application is pending, our partners at Roots, Indus, and PCHS are already continuing to build the Community Health Ambassador program with a focus on chronic disease self-management and prevention. So the work is already happening, and this project would again give us some additional funding to really refine that role specific to type 2 diabetes prevention for families. Next slide, Naza. So here we are. We've come to the, it's 12:53, so we have some time for some questions from the group. I'll turn it back over to Lorraine, who will moderate, facilitate, and we're looking forward to hearing what you have to say, and we'll do our best to answer questions.
Thank you so much to Ian, Nuzna, and Chelsea. What a wonderful summary of the great work that you've done to date in Peel. And it sounds like you're just at the beginning of really being able to start having an impact. So I think I'll just open it up for questions. But first, there was one comment in the chat that I think from Dr. Mary Forehand. And in fact, she's being modest. She's not only an OT, but she's the chair of occupational science and occupational therapy at the University of Toronto. So she said she was really excited to see about the role of OT in management of type 2 diabetes. I would love actually to kind of expand on what Dr. Forehand said. I would love to hear more about what you view as a potential role for occupational therapists, just to kind of open that up. Maybe, I don't know.
Were you asking me, Lorraine, or just the
No,
group?
I was asking the group, actually, the
Okay.
speakers, a little bit more. Maybe you could expand a little bit about the project you had with occupational therapists and type 2 diabetes management.
Nuzna, you want to make an attempt to
Sure.
describe the work that Uniba and Mubina did?
Sure. So we actually had two phenomenal Uniba and Mubina OT students join us for this project. And they really wanted to be hands-on and really wanted to delve in the research. And so again, we like to work with our students to really understand that what their interests are. And part of that was they wanted to gain experience in qualitative analysis. And so we had initially invited them to our analysis meetings. And as they got more familiar with the qualitative methodology process, we asked them how they want to carve out a project for themselves within their larger placement. And that's how this piece was born. So they proposed that they can take the phase 1 and phase 2 data. So all the transcripts, they reviewed them. We were still collecting data for phase 2. So I think they weren't able to do maybe the last 5 participants, but everybody else from phase 2 was included. And they started to analyze the data. So they developed their own code book, again, from a very occupational therapy lens, to understand what role occupational therapists can play in supporting diabetes management among South Asian caregivers. And really, I think the framework that they used was the CMOPI framework to really be able to map out the activities that OTs can support with South Asian caregivers. They reanalyzed all of the data, did the qualitative analysis with our support, and then they were able to draft kind of their findings based on previous literature, but also the CMOPI framework, and map out how that aligned with the role of occupational therapy. And Chelsea and Ian, feel free to add.
That's great. Thank you. I think, go ahead. So I'll just respond to that. I think that's really terrific, because I think what we're hearing and what you guys are really doing well is looking to see where there are existing resources that we can leverage and expertise. I think this is the first thing we have to do, is sort of try to mobilize some of those great resources in the community, and to start by hearing where those unmet needs are and trying to find them. So I think this sounds very exciting. I see that Dr. Baiju Shah has raised his hand. Go ahead, Baiju.
Hi, guys. Thanks very much for that presentation. And it was great to actually get a little bit more on the background. I mean, having read the grant and all of that, it's nice to actually, really get into the meat of that too, which is fantastic. I wanted to ask though, I mean, so, you went through this whole process of working with the partners and coming up with the different ideas and the brainstorming and all of that, and then, settled on one. But are you going to be exploring some of the other ideas, or are there other sort of, plan B, plan C in the background there, or is it kind of all in on this one?
It's a great question, Baiju, and we're definitely not all in this one, but that's the ongoing conversations we're having with our partners, who are, many of whom are still here. I see Zofie's name. I've been scanning. Sadia and Yote. I see lots of names from our partners in the community, so they could certainly speak to this better than we can. You know, we're really here as the research team to support them. So the ideas that emerge are really driven by them, by our partners, by their priorities. So really it's about less for what we're doing as a team, but how we can support them in advancing some of their ideas. So we're really looking to our partners at Indus and PCHS and Roots to give us direction. So as they're continuing to develop programming, we have regular meetings at various network tables, and also as related to these kinds of applications that are going in, it's about like, what is the next thing? And I know that Calvin Key, who's on here, who is also part of this submission, is really interested in youth and young adults living with type 2 diabetes and thinking about designing interventions. So, you know, we've been having conversations about various opportunities to do that, maybe not necessarily specific with South Asian community members, but also potentially some of the other partners who were part of the high priority community strategy. So, you know, it's all through that, everything emerges through those ongoing conversations. So we're definitely not all in. It's just, you know, we're waiting, I think, around direction and continued conversations. And we're happy, you know, as the Family and Child Health Initiative, our program, that's what we do, is we help support the community-driven research priorities that emerge.
And I'll just add to that, Ian, that a lot of the ideas that we did park in the Miro board, we tried to incorporate them in the grant. So there's like within the co-design, we have now proposed that there's going to be educational sessions that focus on diet, physical activity, and mental health, and address the social determinants of health through CHAs, the community health ambassadors. But for example, one of the ideas that came up was an intergenerational community kitchen. And so we really tried to ensure that that piece we were able to take from that and put it into the nutrition programming that we've proposed. And again, this is going back to Ian's comment about like the ongoing conversations and ensuring that we embed that co-design piece within the first leg of the study so that we can go back to the community. We have this Miro board that's available, and including the pieces around project launch and knowledge translation ideas.
Thank you so much. That was great. I wish we could continue the conversation, but we are at 1 o'clock. This was a really wonderful presentation. Please join me in thanking our 3 excellent speakers, and congratulations on all the work. And we really look forward to actually finding ways to actually collaborate with you as part of the Network for Healthy Populations, because what you're doing is highly aligned with what we would like to support. And Ian knows that. So it's just great to kind of bring everybody together and hear about all the wonderful work that's already happening in the community, and that we hope to continue to hear about and continue to support. So with that, once again, I'd like to thank the speakers and for everybody who commented and listened and joined us today. We really appreciate your involvement. So we have our next seminar is on Monday, October 7th from 12 to 1. And we will send registration details and details around the seminar following today's event. But that will be our first joint Novo Nordisk Network and Banting and Best Diabetes Center Research and Progress seminar. And so look forward to inviting you to that. Did I say the wrong date? I'm sorry. Monday, October 17th from 12 to 1. All right, so save the date and you'll hear more about it soon. Thank you everyone for joining, and have a wonderful rest of the day. Bye-bye.